Thank you very much, sir, for including me in this fantastic IC of yours. And modern biometry concepts. We all don't like change, and yet time and tide waits for no man, and for every day something new that is happening, we have to change. And biometry is one aspect where we have to be sure that we are doing the best, and the expertise that we are giving to our patients has to be the best. Therefore, the basics of biometry, just in a small slide, to calculate the power of the intraocular lens, and we have two variables. That's the dioptric power of the cornea and the measurement of the anterior posterior length of the eye. So the key readings are important, and therefore the manual keratometry, the auto keratometry, the pentacam and the OBSCAN are devices by which you can take your key readings. The axial length, of course, again is the most important, and has gone a revolution today by the contact methods which were being used in the past, the non-contact immersion, which is quite accurate and has come in, and the optical biometry. The optical biometry is something that we have to spend a little time on, and this is based on the principle of laser interferometry or the partial coherence interferometry. Highly accurate, no manipulation is possible, and the chances of contact-related complications are minimal. So it works reasonably fast, and the cooperation of the patient is not so much. You do not require a very cooperative patient. The data go in as includes the K value, and of course no anesthetic drops are required. Some important facts that we have to understand. Why should we go in for an optical biometry? Ultrasound and optical axial lens can never be the same. Why? They are two different. Why? Because the axial length, the optical axial length is always longer than the ultrasound. The end point of the optical measurement is the RPE and the Brooks membrane complex at the fovea. So the axis hits the fovea in the optical biometry, whereas the end point of the ultrasonic biometry is the interface between the vitreous and the neurosensory retina, and it's the optic nerve head. So therefore, our manufacturers have come in with the sticker which shows that there is something for optical biometry and ultrasound biometry. Why does this show up? Well, it is to compensate that specific A constant so that the final power is right. So if you have done an optical biometry, so your manufacturer has given the A constant that you need to use, which is different from the ultrasound biometry. So you need to take care of that. The advantages, of course, it's reasonably fast and quite user-friendly, non-contact, of course, and it gives the true refractive length and anatomical axial length, highly precise, and the ametropic patient is tested with the aid of proper fixation. The advantage of measuring the fovea in cases of posterior staphyloma, the coloboma and the silicon-filled eye is very important, and all the results go in. But there are some problem areas even in the optical biometry, and what are they? Well, it does not work in media opacities like central corneal scar, dense PTC, PSC, or very dense nuclear sclerosis. It does not work, of course, in vitreous hemorrhage, pediatric and mentally challenged patients, patients with poor fixation, and minimum amount of pupillary dilatation is required. Of course, the high cost is something that is a deterrent in most of the settings. Therefore, the question that we need to answer today, should we change? Should we replace our old ultrasound biometry by the optical biometry? Well, the answer is no, because on your left you see so many yeses, and on your right as well you see the yes. You need to keep your immersion biometry for everything that the optical cannot do, but use the optical biometry as much as possible. Now let's come to the formula, and the number of different formulae are coming in, and that's a dilemma. So the formulae play a very important role, and the selection of a proper formula for that particular patient is important. We've been using the SRK2. Now, what is the SRK2? It's the regression formula, which is the first and the second generation, and the SRK2 is actually a favorite and is still being used by many surgeons. It includes the third generation formula is a step up on this, and it includes two factors more. That's the surgeon's factor and the AC depth. Hoffer Q in short eyes, which is less than 22 millimeters, Holiday 1 in long eyes, 24 to 26 millimeters, and SRKT in very long eyes. So the third generation formula is important in these conditions, and you can use these formulae for your patients. The fourth generation formula is the latest and the most modified, and you have the Holiday 2 and the Haig's formula. Now, I'm going to consider one or two very specific conditions, and say you had a PCR and you have to put the IOL in the sulcus. What do? You have to change the dioptric IOL if the capsular bag does not allow the bag placement of the IOL. So a thumb rule which works quite well, say if you have a dioptric power of the lens as greater than 28.5, you decrease it approximately by 1.5 diopters. If it is between 17 and 28, you decrease it by 1 diopter. Approximately between 9 and 17, these are myopic eyes, so just by about 0.5. And if it is less than 9, it's more or less 0.5 again. Now let's prefer these formulae. Therefore, for short eyes, the Hoffer Q or the Holiday 2, average eyes, Hoffer Q, Holiday 1, SRKT, medium long eyes, Holiday 1, Hoffer Q, and for the long eyes, the Holiday 1, SRKT. Where can we go wrong? So let's form a checklist. Mechanical errors, calibration not done regularly, faulty transducer, and human errors. Let's call them K-linked syndrome and A-linked syndrome. So what is a K-linked syndrome? Again, the calibration is defective, patient posture and positioning is defective. Irregular Myers are there, and very high astigmatism. So these form the K syndromes. And what about the A syndromes? So again, calibration, the quality and amplitude of the spikes not having been adhered to, fixation of the patient, and misalignment of the probe, inappropriate formula, standard deviation, and expertise of the operator. Now, what do the recent studies say? And what the PCI is supposed to be excellently repeatable and reproducible. And the final IOL power calculation by the PCI or the ultrasound immersion, significant statistical difference is there, but very little clinical importance. So this is one point that we need to note. However, we need to go on, and therefore, let us use the PCI in most of our cases. So what about a post-refractive surgery, which is quite a horror for most of our surgeons? Well, why the problems come on? It's because the central cornea has been flattened and the axial length remains the same. And the keratometers actually assumes a constant index of refraction. Just a minute. And that's what gives us these hyperopic surprises. And therefore, so what do? So the pentacam is there, and the posterior corneal surface can be assessed. The flattest K needs to be taken so that we have as little error as possible. An RGP contact lens method is there. The Haig's L formula is there. On-table retinoscopy is one thing that I do in all my patients, and our senior optometrists do a great job, and I've not had any error as of today, any hyperopic surprise as of today. Online calculators are very good. So the take-home messages for these patients of refractive surgery, nothing is foolproof. We should be consistent. Let's not try out too many different things. Let us aim at a little bit of residual myopia and proper counseling of the patient for an eventuality of an IOL explant and re-implant or a piggyback is there. Thank you very much for your patience.